So I'm not going to look at notes. I just am going to tell you how I got into this. It started as Shiv Nadar University saying, if you can produce a paper. Nobody even put me on a bind that I must produce a paper. So I thought a paper on this subject, now that I had got approval of Dipankar to write on it, I said, why don't I come, Dr. Swaminathan, please come. So I just felt that this is subject of, what do these quacks do? I'll call them quacks. Let's not treat it as something which is objectionable. If it's a simple word to use for today. The Supreme Court uses it, so I don't see why I shouldn't. Now, these quacks, I said, I'll just write a paper on the kind of medication they do, and I was able to find a conduit to get to them. And when I went to Dr. Anand Krishnan, he's a professor of community medicine and man of a lot of experience, he looked at me and he said, you are an administrator. Why are you trying to write an academic paper? So I said, well, I thought that a paper means it should be published. He says, you write a report, you don't write a paper. And you should know more about what happens in Parliament, what happens in the policy making, what happens in the drug laws. You should write on that. So I said, but that's a tall order. I was into September already, and I said, I don't have much time left. So I got into it. And one thing led to the other. The main highlights which I want to bring to you is the magnitude of these practitioners brought out by WHO Geneva in 2016 in a report by Victoria Fan and Sudhir Anand, using data given by the Registrar General of India, opened to them by the Planning Commission, the erstwhile Planning Commission. People had given them this data and told them to unravel the codes to look at what is the highest qualification of a person who claims to be doing any kind of medical practice. And they found out that 52% of the entire community of doctors are unqualified. In rural areas, it's much more. In urban areas, a little less. What is remarkable is that these people are either 10th or 12th pass. If they're graduates, they have nothing to do with medicine. So when I did my field study, I went with a person who has really helped me enormously. I was taken to these quacks and I looked like an elderly woman who was, when I explained, I said, I'm not media, I'm not government, and I can do nothing for you, but I would like to just watch what you're doing and take photographs if you permit. So they said, हाँ, आ जाइए. And what I saw, they were giving IV fluids, injections, steroid injections with dexterity. People were coming with diarrhea, vomiting, the usual things, which happen, which are acute problems, not public health issues. And they were being treated with dexterity, with speed, and with a kind of 8 people sitting in the room. Somebody is a small child, somebody is a 3-month-old baby, somebody is probably about 40 years old. The main thing was they wanted to save the dhyari, next day's wages. Just give me anything and give me something really strong that will get me back. It didn't matter what happens to their kidney or their liver, nothing. So this was all being administered. I took photographs which are in the book and in which you will find, we can go on about syringes and needles. They're all using sterilized syringes and needles. That's not the issue. Where did they learn? They learned from qualified doctors. They set up their own practice. They are the first port of call and they are liked, respected by the poor. And by poor, I mean the poorest of the poor. They are daily wage laborers. These people in rural areas go to these very people, 2 per village roughly. And in urban areas, each slum has anything from, I would say, 60 to 100 of these people. And people go to them and access this medication. If they don't get well, they are able to go straight to the doctors who train them. And through them, they have a wide variety of people to whom they can go and access and say, मैं scooter पे लाऊंगा आपको और आपका काम हो जाएगा. And over there, the fees are all settled. The doctors pay them a 30% commission. They talk and argue on behalf of the patient because their future lies in looking after the patient's interests, not in looking after the doctor's interests. So it's a huge nexus. Then I came to know that they get lot of medicine, a lot of know-how about the latest medicine from two sources. One source is the medical representatives of the finest companies. They keep the best of medicine. The second source is the whole position is to be able to reach the prescriptions given by PGI in Chandigarh or in AIMS and say, हमें वो जो अभी AIMS से जो डॉक्टर साहब ने लिखा है निमोनिया के लिए वो बताओ. And fourth generation drugs are being used with impunity कि आपको हम ठीक कर देंगे. On the one side, one can castigate all this and say this is nonsense. They are breaking every conceivable law. You look at what has Parliament asked about this. Parliament has raised the fact that there are many quacks operating in this country. What does the government propose to do? And government, with respect to Mr. Mishra, has been replying for the last 8 years. I've taken out all the Parliament question replies, simply saying this subject is for the Medical Council of India and the state medical councils to take action on. They can be fined 1,000 rupees and blah, blah, blah. And this is a state subject under the Constitution. End of story. Now, I would say if I had been in the health ministry, I would have written just that. There's nothing wrong with it. It's factually correct. But the fact is, no state government is doing anything. Why? Because the state governments feel that this is something which is going on. Nobody is complaining. Nobody is dying. We are looking after people who are in hospitals, who are having a you might say life and death situation from encephalitis or from H1N1 or some dengue, chikungunya, and you were talking about these quacks. I mean, let them go on. I mean, after all, it's informal. How are we concerned? Nobody has complained to us. Nobody is dead. So any state government is going to take the view it's not really something to really bother about. Why I'm saying it is something to bother about is the following. One, multi-drug resistance is definitely growing in this country, and this is one place where 2 days of antibiotics is not going to lead to anything but you might say drug resistance. Second, you're using tuberculosis drugs and you're allowing tuberculosis medicine to be used without diagnostics having been done. But yes, isko try kar lete hain. The plus side, when I asked a whole heap of doctors, they said, frankly, they're not doing anything different from what an MBBS doctor would do. Second, sometimes they're doing much better than your raw MBBS doctor straight out of medical college. They are far more competent. They know what they're doing. They're not harming anyone. They're not trying to make money. They're willing to wait for their money, 20 rupees, 15 rupees, 50 rupees, 100 rupees, till maybe the end of the month when the laborer has the money to pay. They are the first port of call because people cannot spend time on taking a bus to go and reach a primary health center. This man is in the community. You walk to him. He's been there for years. His father has been there. Each one knows a biradari. You feel comfortable. The man is not going to harm you. Worst comes to worst, he'll see that you meet the right kind of doctor. So I talked to these quacks, and what they told me was, we are qualified. Who says we're not qualified? Here, see this paper. We are under WHO allowed to prescribe, and they gave me a long litany of medication. They said the Supreme Court has said we are entitled to prescribe it. Yes, sure enough, Amar Ujala has a newspaper article saying, yes, these people who have a CMS degree can practice for the community. What is the CMS degree? The CMS degree does not exist. It's not a degree recognized by anyone. This being so, in this kind of a situation, I don't want to take too much time except to tell you that if we don't confront it and we don't take a view on what should be done, we can have 4 or 5 things happening. One, that the state of West Bengal has officially been training these people for the last 7 years. They say that the less harm option is the better option than just sitting back and like an ostrich and saying it doesn't happen. And what has been done in West Bengal is under the umbrella of the JPAL laboratory, the MIT, Abhijit Banerjee, who is, you might say, world famous, and Dr. Abhijit Chaudhary, who talked to me, and there's in my book a whole 2 pages note on what they've been doing for 7 years, incidentally using NRHM funds. So this is also a dichotomy. On the one hand, you say it is quackery. On the other hand, you say the Supreme Court calls them charlatans. On the other hand, you have a state government which is merely training them because they say it's better they do less harm. But then you have research, and I have done quite a lot of secondary research. Jishnu Das of the World Bank, and he has written that his findings are they are no worse than what an MBBS doctor does most of the time. But they will not give up the use of antibiotics even after the training is done. So are we going to live with the situation where we train them and they use antibiotics, or are we going to have maybe a cutoff, a zero tolerance for some things like injections, like steroids, and say to hell with everything else? Are we going to change the Drugs and Cosmetics Act and, as it has been done for ASHAs, make it even more, have a test to see that these people have basic, you might say, abilities, they have skills, they have competencies, and to not use this huge resource, it is colossal. It is more than the number of regular doctors we have in the country. Should we be looking at them as a completely, you might say, demonize them? Should we be trying to use them? When HIV/AIDS came, India was the first to deny it. Our health minister went to Paris and said, "Hamare yahan to koi AIDS hota nahi hai. We have a very, culturally we don't do these things." We know the truth. I mean, you know that we were able to tackle and surmount HIV/AIDS. We had huge problems of maternal deaths and infant deaths, and I compliment Mr. Mishra that through NRHM and through whatever they have done with institutional delivery, they have successfully brought down maternal and infant mortality rates enormously. Please come here. So, if such huge problems could be tackled because there was a recognition that something must be done, this is also a disease of a kind. This has to have solutions. I have given 8 solutions. I will not trouble you with what they are. But we live in a country where we cannot wish this away or wash it away for many years to come. But maybe a deadline that we will not tolerate it 10 years from now. And up to those 10 years, we will work incrementally to do something to see that the poor, by setting up, and this is the last thing I'm going to say, by setting up more and more health facilities, more and more sub-centers, this is not going to work. Ballabgarh, the AIMS runs a huge 24/7 community health center meant to train young postgraduates and graduates there in medicine. Over there, when you have a 24/7 facility, you have any number of doctors, you have people who have the label of AIMS. There are 70 RMPs, UMPs, Bujhola Chap sitting there. And this is a study of AIMS. It's not my study. So it's not going to be the end of the road by saying we will have more and more and more facilities. We'll have to think over whether we need to go back to the licentiate system slightly, not the old licentiate, but a new kind of a licentiate system, wherein the vernacular people are taught a certain amount of medicine which they can use in the rural areas and in the slums where there are no doctors willing to go? And is it possible to then give them some registration under the Medical Council Act, which is exactly what used to be happening till 40s? And if that doesn't work, then probably the one way is to have a carrot and a stick. You make these people your eyes and ears for finding tuberculosis, follow-up of tuberculosis, follow-up of all the public health things that happen, and tell them you will remain on our rolls as long as you behave. And behavior means we will accept this, we will not accept this. These are some of the ways that we could tackle it. But to say it does not exist, we don't know, it doesn't happen in our country, or it happens in some areas only, these are all just, you might say, trying to put off the bad day, and really it will affect us when we find multi-drug resistance, when we find tuberculosis drugs not working, and this is probably one of the root causes of what is happening. So I won't take more time. I'm sure the discussants will give you much more light, not on my work, but on their views on this subject. Thank you.